Thank you very much for joining us this afternoon. Hopefully we'll just keep you just around about an hour, giving you a quick update on GP CPCS in Greater Manchester. My name is Alison Scowcroft. I work for CHL, which is the pharmacy provider company for Greater Manchester, and I'm part of the GP CPCS working group, along with my colleague Ricky, who's also here today.
Good afternoon, everybody. I'm Ricky Smeaton. I'm the Principal and Responsible Officer for Greater Manchester LPC. And as Alison mentioned, I'm part of the GP CPCS working group.
Thanks, Ricky. We've got some slides to take you through today, myself and Ricky. So I'm going to lead the beginning of the presentation, and then I'll hand over to Ricky halfway through. Just to give you a bit of a background on the Greater Manchester Healthcare Academy. Hopefully everybody on the call is aware of the Academy, which is a partnership between the NHS and community pharmacy. The focus is engaging and supporting community pharmacists to achieve their full potential in service delivery. We do run lots of training and events for community pharmacy, and we do support the whole pharmacy team. So the Greater Manchester Healthcare Academy was founded by the Greater Manchester Health and Social Care Partnership, the LPN, Greater Manchester LPC, Bolton LPC and CHL, and we're also supported by the CPPE. Quick note around service delivery in Greater Manchester. The future of community pharmacy depends on us all. It's really important that commissioners and others see our potential in community pharmacy, and we're working very closely together across Greater Manchester to support contractors and pharmacy teams to embrace a new service-led future in line with the CPCF. So we really do need community pharmacy to step up and embrace these new service opportunities as they are coming out, particularly through the CPCF. And we need to deliver what we promise, or else we do risk services being decommissioned. We do need to work together to make sure that the NHS is aware of community pharmacy's value and credibility as a provider of health and care. A little bit of housekeeping for webinar in Zoom. You should all automatically be muted. If you could just check that you are on mute, that would be really great. If you're not, you should be able to find the little microphone somewhere in your taskbar and make it so that it's red and crossed through. Just then there's no interference with the presentation as we deliver it. We will have the opportunity for questions at the end. So if you do have any questions, if you could keep them till the end of the session, we'll make sure there's enough time for questions. And then you can either come on screen and talk to us, or you can put them in the chat box as you prefer. The agenda today, we're going to talk through accepting a GP CPCS referral and also completing a consultation. And then Ricky will talk to you around making an escalation, some general information around relationships, and then we'll have the questions and answer at the end.
How do I get the speakers on here?
If you could just pop yourselves on mute, that'd be really great, please. Thank you very much. Okay, the aims and objectives of today's session is to provide you with some guidance and support on how you can make GP CPCS a success in your pharmacy. We want to reaffirm to you how your team can support with the delivery of the service, and also to remind you of the contractual requirements for service provision. We're going to share some best practice information with you and some top tips based on 8 to 10 months of referrals and working with pharmacies and general practices within Greater Manchester. And we're also going to share some examples with you of presenting symptoms and best practice completed consultations, including those really important, concise but complete consultation notes. Just thought we'd start off today with giving you some statistics. So currently we've got 186 practices live across Greater Manchester. That's just less than half, so 44% of practices are live across Greater Manchester, and of those 138 are actively referring, so there is a little bit of work to do with some of those who've only just gone live. We've got 93% of Greater Manchester practices currently engaged, so that means the remaining, whatever that is, 40 odd percent will be due to go live with GP CPCS in the next 3 to 6 months or so, which is fantastic. In terms of referrals, we've had almost 9,000 referrals sent in the last 10 months or so to 445 pharmacies. The completion rate by community pharmacy is just less than 70% of referrals being completed within 12 hours, which is a tad low, and we do need to do something about that to address that referral completion rate and get it increased a little bit. We're seeing a significant percentage of referrals for GP CPCS for children aged 10 and under. So from a clinical perspective, if we've got pharmacists on the call, you need to make sure that you're up to speed with your paediatric minor illnesses. And almost a third of all referrals across Greater Manchester are resulting in advice only. So really important, really a vital outcome from a CPCS consultation is advice only to the patient, where the patient just needs some reassurance about the symptoms that they're experiencing, quite commonly around the duration of those symptoms. And our top 4 presenting symptoms across Greater Manchester, I'm sure these probably won't be a surprise to those of you on the call who are live with GP CPCS. Cough and cold type symptoms, very common. Skin and rashes, again, are really common symptoms, along with sore throat and earache. So if you're going to do a little bit of CPD after today's session, they would be the areas to focus on if you need to get yourselves up to date with any of the clinical, nice clinical knowledge summaries, for example, in any of those therapeutic areas. So we're going to start at the beginning of the process, which is accepting a referral from a general practice. It's really important that you involve your whole pharmacy team in this process. It should not be the pharmacist's sole responsibility to be checking the system for referrals in PharmOutcomes or in your NHS mail. You need to have pretty much everybody in the pharmacy able to access the shared mailbox and able to access PharmOutcomes to check those referrals and then flag them up to the pharmacist for them to then complete. Excuse me. So make sure you brief your team, make sure everybody knows how the service operates, give them a simple overview of that. You can use Annex A in the PSNC toolkit to help you with that. Give your staff some time to familiarise themselves with the service spec and the toolkit, and talk together as a team how you can work together to make this a success. Make sure people have got the daily activities nailed in their heads. You might have posters on the wall or reminders popping up. Make sure that everybody knows what needs to happen in terms of checking for those referrals. And particularly locums as well. Make sure that any locum pharmacists who are working in your pharmacy know that you've got live general practices close by who are going to make CPCS referrals into your pharmacy. Make sure that you're aware and all of your team is aware that this service must be delivered throughout all of the pharmacy opening times. If you've signed up to deliver the CPCS service, that's an inherent part of the service specification. Excuse me. So make sure that your locums and any relief staff that you have working in your pharmacy are aware. And there is a locum guide and a locum checklist available on your LPC website to help you to pull together some of that key information. If you're in a pharmacy that opens longer hours, think about how you're going to hand over patients at shift changes. If that consultation hasn't been completed, you may need to use a diary or a communications log of some sort to make sure that those referrals are passed over to the next pharmacist who's coming on duty. And make sure that enough team members have access to PharmOutcomes and to the NHS shared mailbox. So there should be somebody in the pharmacy throughout all of your opening hours that's able to access those two systems. And make sure that everybody in your team knows how to identify a potential CPCS referral. In terms of checking for referrals, it might be helpful to nominate people within your pharmacy to do this, making sure that everybody knows how to do it. You need to be checking PharmOutcomes and your shared mailbox regularly throughout the day. At the very least, you should be checking first thing in the morning, around about 2:30, which is the cutoff time for same day completion, and then in the evening before you close the pharmacy. But really, you should be checking on a regular basis every hour or so, particularly if you've got active practices in your area. It's no excuse not to check on a regular basis. The referrals will drop into the services tab in PharmOutcomes and show us an outstanding record, as you can see there in the screenshot, and they'll also be sent to your NHS shared mailbox or the email address that you have input into PharmOutcomes as your management email. So there's 2 ways that you're going to get notified of those referrals. So there's no reason to miss them. What you should be doing within your pharmacy, hopefully, is your staff should be monitoring those systems, the NHS shared mailbox and PharmOutcomes, to check for any referrals that have come through. And they should be then highlighted to the responsible pharmacist who's on duty that day. You must contact the patient within 2 to 3 hours of the referral being received. This is one of the key areas that we quite often get feedback from general practice that is not working very well, unfortunately. We are telling general practice you will pick up these referrals within 2 to 3 hours, so it's really important that you keep within that time frame. This is really important, especially if you're working with a locum who might not be familiar with the service in your pharmacy. So make sure that your staff are checking regularly for those referrals and are highlighting them to the pharmacist and explaining that this needs to be picked up within 2 to 3 hours. If the patient is uncontactable, please make several attempts to contact them throughout the day. And make sure, if that is the case, that you press the accept button in PharmOutcomes, even if the patient is uncontactable. If you've pressed accept, that tells us you've seen the referral and you're trying to do something with it. It means that you've acknowledged the referral. So don't just leave it as outstanding. If you're making contact with the patient, then press accept. Make sure that any referrals you receive before 2:30 p.m. are completed that same day. And if you do receive any referrals after 2:30 p.m. in the afternoon, you still need to assess them, because there may be some level of urgency with that patient where you do need to complete that consultation the same day from a clinical perspective. If it's not assessed as urgent, then you do need to make sure that's completed the next working day at the latest. And again, think about pharmacists on duty and if you need to leave notes for different pharmacists who may be in the following day. If you've got any patients who are uncontactable after 24 hours of receipt of referral, then you must reject the referral. So press reject and put some concise notes into that rejection notes box, explaining that the patient was uncontactable and that there have been multiple attempts made. At some point, those rejection notes are going to go back to general practice. They haven't been sent back to general practice until recently, but there has been, or there is due to be, a software update that means those rejection notes will be sent back to general practice. So please make sure you're professional and concise in the notes that you enter into that field. We're not quite sure when that change is going to happen, unfortunately, about when those rejection notes are going to go back, but it is due in the next month or so. So if the patient's not contactable after 24 hours, then please reject the referral and put those notes in to explain the reason for the rejection. Just to give you an overview of the referral process, this is a slide that we also share with general practice teams when we're delivering training to the receptionists and the care navigators within general practice. So an overview of the referral process is that the referral is sent electronically from the GP to the pharmacy. The GP tell the patient to wait for contact from the pharmacy, and therefore the pharmacy then must proactively contact the patient within 2 to 3 hours. Please don't wait for these patients to turn up in your pharmacy. Please don't wait for them to phone the pharmacy to follow up the referral. The process that's been agreed in Greater Manchester is that it is the pharmacy that must contact the patient proactively following the referral. The reason that this has been agreed is because it allows you to make contact with the patient at a time that suits you in terms of your workload and your capacity. Whereas if the patient turns up at the referral, you have to see them and deal with them there and then. So please make sure that you are proactively following up these referrals within 2 to 3 hours of that patient being referred. Only if the patient has not been contacted within that 3-hour window should they then contact the pharmacy. But if you're on top of your referrals, obviously that should not happen. As I mentioned on the previous slide, there is a 2:30 p.m. cutoff. So you need to make sure that you're picking up any referrals sent by 2:30 the same day. And as I said, make sure you use your professional judgment to assess if a patient does require any urgent support for referrals that are sent after 2:30, or particularly if the next day is a non-working day. So for example, a referral sent at 4 o'clock on a Friday afternoon and your pharmacy doesn't open over the weekend, you need to be looking at those referrals and ensuring that they're picked up that afternoon if there is an urgent clinical reason for that. So key points from this slide to remember: you must contact the patient proactively 2 to 3 hours after the referral is sent, and remember that 2:30 p.m. cutoff. Anything sent before 2:30, you do need to pick up and act on that the same day. As I've said, you should be contacting those patients within 2 to 3 hours, but you might still get some patients who contact your pharmacy directly. They're too impatient, they can't wait for you to ring them. They might phone you or they might present in the pharmacy. It's really important that your team, particularly your team on the counter, are aware of how to identify these patients, because they may not tell you that they've been referred from the GP. They may just present in the pharmacy. And if you don't pick up that they are a GP CPCS referral and you process this as an over-the-counter sale, then you're not going to be able to claim payment for the consultation. So make sure that your team are hyper vigilant for any patients presenting within the pharmacy or phoning up who may have been referred. So they might tell you that they've been sent by the surgery. They might tell you that they've contacted the doctor and they told me to come here. So it's some of those key phrases you need to think about for your teams as to how they can pick out any patients presenting in the pharmacy who may be a GP CPCS referral. If in doubt and if the patient's not sure, always check your PharmOutcomes system and your NHS shared mailbox to see if there is a referral there. We don't want you to miss these referrals and process them over the counter, because then you're missing out on your £14 consultation fee. And also you don't get that feedback loop back into the practice. Obviously, access to NHS mail is a big part of the CPCS service, because you need to be able to access NHS mail from majority of people within your team throughout your whole opening hours. So if you need to request additional staff mail accounts, there are 2 processes to follow depending upon how many user accounts you have. If your pharmacy has less than 10 user accounts, then whoever is your shared mailbox owner can make a request to the Pharmacy National Help Desk using that email address there, pharmacyadmin@nhs.net. That must be sent from your shared NHS mailbox, and you need to include the name of the pharmacy team member you want to set up an access for, an alternate email address and their mobile phone number, because those 2 bits of information, a password will be sent to the alternate email address and the mobile phone number, just for the purposes of setting up the access. So if you've got less than 10 user accounts already, you can add new users yourself. If your pharmacy already has 10 user personal accounts, then the shared mailbox owner needs to email the regional NHS England team using the england.gmtop@nhs.net address. You need to state the reasons why you need more than 10 accounts, and they will then approve that request. If that request is approved, then the regional team will email the Pharmacy National Help Desk on your behalf. Again, you'll need to provide a personal mobile phone number and email address so that that password can be sent through to them. And don't forget, people need to update their passwords every 365 days. Please don't let your passwords expire, because it becomes a bit complicated to sort that out. So keep on top of that and make sure that everybody is renewing their password every 365 days. You'll need to activate your NHS mail account once you've received that username and temporary password. So you activate it by going to NHSnet and clicking the login button. You enter the username and then you enter the password that was sent to your mobile phone as a text message. You should get a pop-up on your screen around the user agreement, which you have to review and accept. And then you should receive an email confirming that you've activated the account. Please remember that activation needs to be undertaken by each person with an NHS mail account. Helpful little tip: if you don't receive your new email address, your mailbox manager can check the linked accounts in the shared mailbox admin, or you can check People Finder in NHS Mail. It's also good to do a little bit of housekeeping on your shared mailbox. If you've had any staff members leaving the pharmacy, then you should remove them from the shared mailbox. It needs to be done by the mailbox manager. So if you go into the settings for your shared mailbox, you can see at the bottom left-hand side here on the screenshot, there's a list of the users. What you need to do is just click the cross next to their name of the person you want to remove from the shared mailbox, and then press update at the bottom. Just remember, don't remove an owner before first adding a new owner. So hopefully that process is quite straightforward and easy to use. As I mentioned before, in PharmOutcomes, you have a management email that's set up, and that's where any referrals that are sent through PharmOutcomes will also be sent to the email that you've entered into your management email. So it's an important function of PharmOutcomes. If you go to your PharmOutcomes system, if you go from the home page, there is a section on the side that says update my organisation details. You can put any email you want in there. It does not need to be an NHS Net email as secure, because no patient identifiable data is sent as part of this alert that you've got a referral. So you can have those sent to whichever email inbox you want them sent to, whichever one is appropriate for your pharmacy and is easily accessible by all the team. So if you need to change that email address that's set up as the management email, then you can do that yourselves from within the PharmOutcomes account. Just a quick reminder of your contractual requirements. You've signed up a contract to deliver the community pharmacist consultation service. The service must be available throughout your full opening hours, which includes your core and your supplementary hours. It does state within the service specification that your pharmacy team should regularly check the IT system for referrals, and as a minimum, you should check the NHS shared mailbox first thing in the morning and last thing in the evening. So that is a contractual requirement that you check at least twice a day. I would recommend a third check around about 2:30 at cut-off time as well. You can ask for a temporary suspension of the service if you feel that that is appropriate, and all team members, including locums and relief pharmacists, should be aware of the procedures to follow in the event of a temporary suspension of service. You should make sure that you've got key contact numbers easily accessible and recorded in your standard operating procedure. We've talked quite a lot about IT support, but just to clarify that all team members, including locums and relief pharmacists, should be aware of how to contact if they need any support for the PharmOutcomes system or for NHS shared mailbox. And again, those key contact numbers should be easily accessible and recorded in your standard operating procedure. Final note on locums: when you are booking locums to work in your pharmacy, make sure that locum is aware that the CPCS service is being provided, particularly GP CPCS referrals, and ensure that they can provide the service. We get quite a lot of feedback from general practice around issues where managers are on holiday, locums are in pharmacy, and the service is not being provided to the level that it should be. So that was accepting a referral. We're going to move on now to completing a consultation with a patient. So this is the Greater Manchester Referral Protocol. This is what I call the red and green list. And we spend quite a lot of time with the general practice teams looking at this list and helping them to identify and understand which patients are suitable to be referred. So general practice teams know that they can only refer patients who have symptoms that are on the green side of this list, and that they shouldn't be referring any patients who have any of the red flags that are listed on the red side of the list. So there's a lot of information provided to general practice to make sure that they are getting the right patients to refer to you. From a pharmacist perspective, you should be comfortable and confident with dealing with all of these symptoms on this referral protocol. So again, if there's any CPD that you might want to do after today's session, just have a reflect on the symptoms that there are on the green side and identify any gaps that you may have and address them after the session today. Consultations should ideally be completed within 12 hours of the referral. That's what the service specification requires. So you must complete the consultation within 12 hours of referral, with that patient contact, that first phone call happening within 2 to 3 hours of the referral being sent. You can deliver consultations by phone or face-to-face. I would suggest that anybody who's referred with symptoms which warrant direct observation of the patient, you should do a face-to-face consultation. So particularly patients with rashes, skin problems, acne, or any kind of wound problems, you really need to see those patients to be able to deliver a proper consultation with that patient. They really shouldn't be done over the phone. And please also ensure that you take the patient's preferences into consideration when you're deciding whether to do the consultation on the phone or face-to-face. A patient may prefer a telephone consultation, or they may prefer to have a face-to-face consultation. So please take the patient's preferences into account. As I mentioned at the beginning, almost a third of all referrals result in advice only to the patient. So the self-care advice and treatment advice that you give to the patient is really important. Remember that you can print off patient information leaflets as part of the consultation. Indeed, that is expected as part of the service if it's appropriate. And promoting that self-care messaging is really important, as is the safety netting advice. So you do have to tick the box on PharmOutcomes to say that you've given this to the patient, but it's really important that you give them that safety netting advice. So if your symptoms do not improve or become worse, then either come back to see me or seek advice from your GP. In the next couple of slides, what we've done is pulled out the most common referral symptoms in Greater Manchester and looked at what the NICE clinical knowledge summaries, current evidence base and practical guidance on best practice is. So the next 3 slides, all the information is taken from NICE CKS. If you're not familiar with that tool and you haven't spent much time on it, please do sit down and have a look at it. There's loads of really, really useful information on there to help you in delivering your consultations with these patients. I'm not going to go through each one of these in detail. We will send the slides to you after today's session so you can review them. And obviously it's all available on the NICE CKS website. But just to pull out cough as an example, NICE CKS states that an acute cough usually persists for up to 3 to 4 weeks. So if you're being referred a patient who's had a cough for a week, then really you need to be providing them with some reassurance that actually that's quite normal duration of time for the symptoms to be in place and that they can persist for up to 3 to 4 weeks. The best thing you can do for cough is self-care treatment with paracetamol or ibuprofen or over-the-counter cough medicines. Red flags to look out for with a cough is a high respiratory rate, over 30 breaths per minute, any tachycardia or low blood pressure, low peak expiratory flow if you're able to assess that, and the use of accessory muscles of respiration, which is usually quite easy to see when you're directly observing a patient. So just think about those red flags for a patient with a cough. On the next slide, we'll just pull out conjunctivitis on here. So the main point with conjunctivitis, particularly from a NICE CKS perspective, is trying to distinguish whether it's viral or bacterial. In practice, this is usually quite difficult to do, but actually a viral conjunctivitis will have mild to moderate erythema, less discharge, and it's usually quite watery. The recommendation for treatment for viral conjunctivitis is self-care treatment only, bathing the eyelids with boiled and cooled water, using a cold compress, potentially lubricating eye drops if needed. It's self-limiting. It usually resolves within 1 to 2 weeks and doesn't require any treatment. Obviously, a topical antibiotic is not going to be effective against viral conjunctivitis. If you feel that conjunctivitis is bacterial, you're going to see a more purulent discharge with crusting and mild or no pruritus. Again, it's self-limiting. NICE clinical knowledge summaries recommends that treatment should not be provided unless the symptoms have not resolved within 3 days or there's some sort of severe or some personal circumstances which require a rapid resolution of the infection. So bacterial conjunctivitis is self-limiting and can resolve, as I said, within 5 to 7 days without treatment. Clearly, from a patient perspective, they may be coming to you expecting a treatment of some sort, so you may need to manage that conversation appropriately with the patient. Red flags for conjunctivitis: any reduced visual acuity, any marked eye pain, any history of trauma, and particularly soft contact lens use with corneal symptoms. So conjunctivitis, a good one. We do see a lot of referrals for conjunctivitis for CPCS. And then final one, just to pull out for you, in the GM referral protocol, it does include pain or swelling in the lower limb as one of the symptoms which can be referred. The view from the pharmacists that I've spoken to around this and the GPs is that we're really in the back of our minds got DVT in a patient who's presenting with pain or swelling in the lower limb. So in the absence of an injury to the limb, a slip, a trip, fall, bite, sting, or some sort of laceration, it's unlikely that swelling could be minor, and pharmacists should consider DVT and other potential scenarios which might require assessment by the GP. Red flags for your suspected DVT would be unilateral or localized pain when walking or weight bearing, any tenderness, changes to the skin, vein distension, and just polishing up on the risk factors for DVT, recent surgery or hospitalization, significant immobility, hormone treatment, so contraception or a HRT, pregnancy or postpartum, also suspected fracture or dislocation, nerve damage or a wound penetrating the joint. If you're clear that there's pain or swelling in the lower limb, is definitely not a DVT, so it's more likely related to an injury to the limb, then you're more likely to be looking at a sprain or a strain, which can present with swelling, tenderness, pain and bruising. Nice CKS self-care treatment for sprains and strains includes paracetamol or topical NSAID as first line, with an oral NSAID if needed. We've got the price algorithm there, so protect, rest, ice, compression and elevation. Advise on safe return excuse me, to usual activities and sports, and consider medical review after 5 to 7 days if the symptoms have not improved or worsened. So just a little bit of a whistle-stop tour there of some of the common referral reasons in Greater Manchester and how best to deal with those from a clinical perspective. Just finally, in terms of completing a consultation, it's really important that you enter complete and appropriate data into PharmOutcomes. Everything that you enter on the consultation record is visible by the practice. So please make sure that you enter appropriate, factual and professional information. If you do need to signpost or escalate the patient, whatever you've written will help that GP to assess what's required. We have a really variable level of notes that are entered into PharmOutcomes. You can see some of the good notes in the blue box in the middle there. Quite simple and straightforward, quite brief, but clinical and to the point. And then we've got some examples of some very poor notes. So somebody's written red flag symptom. Well, as a GP, I would like to know what that red flag symptom is. What is it? What's happening with this patient? What are they experiencing? That really doesn't tell me anything. Can't sell, again, not really helpful at all to the GP. And having just been through what the NICE CKS says around conjunctivitis, not quite sure why somebody would refer a patient back to the GP with viral conjunctivitis. If they've gone to the trouble of diagnosing the patient as having viral conjunctivitis, then clearly they should be able to give that appropriate self-care treatment and advice. So some not great examples on the right-hand side in the orange box. So please make sure that you're entering appropriate factual and professional information into PharmOutcomes. Whoops, sorry, I just went back one by mistake there. So I'm going to stop talking now and hand over to Ricky, who will take you through making an escalation and relationships.
So on occasion, during the consultation, you may identify that a patient requires an onward referral to either another healthcare professional or back to the general practice team. Next slide, please, Alison. So as you'll be aware, there are two types of escalation. So there's a non-urgent escalation, which is either patient signposted to another healthcare professional or back to the GP, or an urgent escalation where the pharmacist believes that the patient requires an urgent appointment at the practice. So we believe that there may be some confusion across our community pharmacists on how escalations are working for GP CPCS consultations. So we'd like to make it absolutely clear that the pharmacist completing the consultation with the patient must make contact with the practice. And this is for both non-urgent and urgent escalations. PharmOutcomes unfortunately does not do this for you, as Alison mentioned before, when you send over the consultation note. So you must be making a separate phone call or an email via NHS using the contact details that have been supplied to you from the practice. So how do you make contact back with the practice and where can you find this information? Next slide, please, Alison. So all non-urgent and urgent escalation details for the practices will have been shared with community pharmacies via NHS mail prior to each of the practices going live. If you've missed those emails or you haven't got the correct contact details to make the escalation, then this is where you can find them. And you can log on to your PharmOutcomes, which all GM pharmacies should have access to. And then on Annex C information page on the left-hand side of the screen, you should be able to see the GP CPCS additional information, and you can click the click here link, and that will be that'll signpost you to all the non-urgent and urgent escalation details for the practice. So Annex C is being updated once a month. So if there is any missing information on there, there isn't contact detail, please do contact your local LPC, let us know. We will work with the practice and the working group and make sure that all the information is available to you in the pharmacy. Next slide, please, Alison. Cheers, thank you. So as you know then, for non-urgent escalation, the pharmacist identifies an escalation is required and they must make contact with the practice themselves in that agreed way. So either via email or telephone, whichever the practice has stated. And the pharmacist would then complete the professional and comprehensive consultation record, as Alison went through before, for the practice and in that timely manner. And then it would be for the practice then to allocate an appointment or the other healthcare professional for the patient or deal with how they see fit. Pharmacists must not ask patients to contact the practice themselves. What we're really trying to do with GP CPCS is bring community pharmacy and general practice shoulder to shoulder. So it's not the patient that is expected to be relaying that information. The pharmacist must make that contact with the practice themselves. And the referral data that we've got available to us, it does show that some of our pharmacists are including consultation notes, which sets an expectation with either treatment or specific outcomes for patients. So a really good example of this one will be stating that the patient requires antibiotics. So whilst this might very well be true, and you know that the patient will require antibiotics, telling the patient that it only sets their expectation on getting them. So pharmacists are reminded that the decision on prescribed treatment rests solely with the prescriber. The same way that the receptionist shouldn't be telling patients that they will get a product on minor ailment schemes or any other specific outcome in the pharmacy. That is for us in community pharmacy to decide. So in the same way, prescribers will decide if the patient requires antibiotics. Next slide, please, Alison. Thank you. So for urgent escalations then, this is exactly the same as non-urgent. It might just be that the practice has indicated that the pharmacist is required to make a phone call rather than an email. And again, we'll follow the same process. So completing those comprehensive consultation notes and not setting any expectations with patients. We would like to remind everybody to remain vigilant, especially when looking for red flag symptoms. And there has been a number of GP CPCS referrals that have been escalated onto urgent care or A&E. So whilst these types of escalations are in a minority of cases, we have seen a number of patients being referred onto A&E in Greater Manchester due to some of that fantastic work that our pharmacists are doing. And some of those examples and what we've seen are, so patient presenting with chest pain, absolutely, the pharmacist suspecting a heart attack, that one, yeah, absolutely needs to be referred on to urgent care or A&E. Patient with a rash that's failed the tumbler test, whereby the rash hasn't disappeared. And also patients presenting with fever and worsening neck pain where the pharmacist suspected meningitis. So if you do have to escalate to urgent care or A&E, you might wish to consider notifying the practice directly that you have referred that patient, so then they've got a full understanding of what has happened with that patient. Next slide, please, Alison. So I'm now going to take you through the final part of the session, which is improving relationships with general practice. Can you just go on to the next slide again, please, Alison? Thank you. So how will you work with your local practices? So hopefully you're already doing this on a regular basis and you've got some well-established great relationships. So GP CPCS, whilst it's being implemented and deployed at GM level by myself and the working group, it's really, really important that the success of how this goes really does depend on those local relationships that you have with your local practices and how you communicate with them. So we are encouraging all pharmacies to firstly get in touch with your local practice, talk to your practice manager If you don't know who the practice manager is, find out who they are and have a chat with them. We are also asking our general practice colleagues to get in touch with our pharmacies as well. So there's that open channel of communication. Really get an understanding about where they are as a practice, how many requests are they getting for appointments on a day-to-day basis, and is that changing, is that fluctuating perhaps on a specific day of the week, perhaps Monday after the weekend, for example. It also will give you an opportunity to keep them updated with where you are in terms of your capacity and how many referrals you can accept on a daily basis, and is that changing for you and your team? So we know that how stressful it has been across primary care at the moment, and how much pressure is on you and your teams and the entire system, and that things can really change on a day-to-day basis, especially for our community pharmacy teams. So what we're asking you to do is make sure that you regularly keep the practices up to date with where you are on an ongoing basis. What we don't want to see is a poor patient experience, because, for example, the pharmacy is experiencing capacity or workforce issues, and they just haven't been communicated to the practice. The practice may very well just continue sending patients through who are expecting the pharmacist to contact them and who are going to help them, and the patient hasn't received the quality of service that they were expecting. So it's super, super important to ensure that regular communication with practices continues. And we've given some examples here on the screen of the types of questions that we've seen general practice asking pharmacies, and vice versa. So they're absolutely there for you and your teams to help you. Next slide, please, Alison. Thank you. So we've been working really closely with pharmacies and practices that are already live across Greater Manchester, and we've collated some feedback which has indicated that there are some things that both practice and pharmacies can do to improve the smooth running of the service, which I'll go to in a little bit more detail in just a moment. We've pulled together some really helpful do's and don'ts for both our community pharmacy teams and practices based on the feedback of those practices and pharmacies that are live with the service. The next slide, please, Alison. Thank you. So one of the things that we're asking pharmacies to do is, if you're experiencing pressure and constraints that prevent you from providing the service in line with the service specification and the locally agreed protocols, please do let your local practices know at your earliest convenience, and please do notify your LPC. If you are a multiple, please do let your head offices know as well, so then that they can put some support measures in place for you and your teams. And if you believe that you're unable to provide the service on a more long-term basis, then please contact the local area team, so Greater Manchester Health and Social Care Partnership, on the england.gm top email address that you can see there in the screen, and they'll be happy to temporarily suspend you from the service, as Alison mentioned before, and remove you from that referral pathway until you are ready to start providing the service again. And we've just made a note here just to say that please do remember that there is a patient behind every single one of these referrals. So whilst they may not be in front of you or in the shop or at the counter, there is a patient there that's been told by the practice to wait for the pharmacist to contact them. And they believe that they're going to get looked after and contacted by the pharmacy. So if you are unable to deal with referrals, that is absolutely fine, but please make sure that you escalate it via the right channel if you're unable to do so. And it's really, really critical to the success of the service. And we really do run the risk of practices losing faith in the service itself and in community pharmacy in general, that we won't deliver services and that patients will be impacted negatively as a result. And we have actually seen instances where practices have stopped referring patients due to pharmacies regularly missing or not actioning referrals. So super important. If you don't think you can continue, please do shout up. Next slide, please, Alison. So what are the things then that we can do in community pharmacies to ensure the smooth running of the service? So like I said, we've pulled together some do's and don'ts based on the feedback from where we've got practices and pharmacies live. And I won't go through all of them, but I'll just pull out some of the most pertinent ones. So as Alison mentioned before, ensuring all your team members are trained, particularly locums and reliefs, and that you're not just relying on one member of staff to do the service. We have seen, as Alison mentioned before, we've seen some instances where pharmacies are unable to provide the service on a particular day, where the regular pharmacist is off, for example, and they've got a locum in instead. So please remember that you must be able to provide the service for your full contracted opening hours. Again, farm outcomes, making sure that is regularly being checked. Again, as Alison mentioned, that could be done by any member of the team, doesn't have to be the pharmacist. And please ensure that the patients are contacted within that 2 to 3 hour window. And if a patient is uncontactable, as Alison mentioned, accept the referral on the system so we know that it's being picked up and it's not just been left. Also, as Alison mentioned, completing those comprehensive notes and ensuring that the correct method of comms back to the practice when escalating back. So that's going back to those email and phone numbers that you can access on Farm Outcomes. What do we not want to see our community pharmacies doing? So please do not wait for the patient to contact you. Unlike 111, it is the pharmacist who is expected to contact that patient, which, as Alison said, helps manage workload within the pharmacy. Please do not leave referrals unactioned, nor do we want you to see you wait until the end of the day to complete them. And please do not ask the patient to go back to the practice themselves. And remember, we shouldn't be setting any expectations in terms of treatment or outcomes. Next slide, please, Alison. We're going to open it up then to the Q&A session, mindful that we've spoke at you now and given you quite a lot of information to digest. So over to you guys. Is there anything in there that you're not quite sure of? Is there anything that didn't quite make sense? Please either use the chat box, or if you feel like it, please come on screen, pop your hand up. We are here to help you. If you've got any questions, please go ahead. Thank you.
I think we've got a couple of questions in the chat box, Ricky. So yeah, somebody's asked about recording the session. We are recording. This is the fourth of 4 sessions that we've delivered. We've recorded all of them, so we're going to watch them back and pick the best one and then make that available to community pharmacies across Greater Manchester. So we'll make sure that you have access to a recording if you want to share this with any of your colleagues after the session. Probably be next week now before we get round to publishing that, but we'll get a link sent out to you. And we'll also send copies of the slides as well to everybody who registered to attend the session today. We've got a question from Haroon. We received CPCS referrals but haven't received any GP CPCS. Do we need to activate it somehow? Do you want to pick that one up, Ricky?
Yeah, I can pick that one up. So if you are signed up to receive the 111 referrals, then you should automatically be set up for GP CPCS referrals. So there's nothing that you actively need to do or activate. It could very well be that practices in the area are either not live or they have just gone live and are only doing a small number of referrals in the first place. And it might be that your pharmacy hasn't received them yet, but super important to keep regularly checking. We send an update to pharmacies as and when each practice is going live. And we also have a bi-weekly newsletter that lets pharmacies know which practices are going live in the area. So if you're not already signed up to those newsletters, please visit your LPC websites and sign up. Have I missed anything with that one, Alison?
No, I think you've got it all there. Absolutely. Yeah, it might be worth checking those updates that are sent out by the LPC, Haroon, just to have a look at the practices in your area and see what stage they're at in terms of deployment. They might have some training books in or have a go live date agreed, for example. So those updates that get sent out are really helpful for you to understand where the GPs in your local area are up to. And then there's another question in the chat box. Where do we find the numbers to escalate to if needed out of hours, for example, A&E, etc.? So there is, when you record the consultation in Farm Outcomes, when it asks you if you need to escalate the patient to anywhere else, when you click yes on the escalation, then you will get some big red boxes that appear that have got telephone numbers in of your local urgent care centres, urgent treatment centres. So it appears within Farm Outcomes. And there's also the Annex C page in Farm Outcomes that Ricky signposted you to for the GP contact details. On that same place, there's an Annex C, which also has all the local contact telephone numbers for each of the 10 Greater Manchester localities for the urgent treatment centres. So 2 places that you can go for those escalations out of hours. In PharmOutcomes, when you're actually delivering the consultation in the red boxes, and then secondly, in Annex C in PharmOutcomes, you can go into there, and I think you can probably print that off as well, and then you've got it handy. So hopefully that answers your question, Haroon. Does anybody else have any other questions for us? Shamila, we're having difficulty getting in touch with the practice by telephone as they're always engaged and they don't pick their phones up. Any ideas? Yeah, it's a really difficult one, Shamila. We are, in some cases, practices are providing us with a bypass telephone number or a back office telephone number for those urgent escalations. So if the practice has provided that to us, that will be the number that we have supplied to the pharmacy before the practice went live, and that will be the number that is in the Annex C GP information on the screen that Ricky shared. If the practice hasn't provided us with that back office number, that bypass number, then obviously we don't have that to pass on to the pharmacies, unfortunately. I believe some practices just don't have a different number that they can use. But I would suggest in the first instance, if you've checked the Annex C information and the number that's been provided to you is their usual surgery number, perhaps the best approach would be to have a conversation with the practice about it, explain to them what the issues are that you're experiencing, particularly if you've got any urgent escalations where you have struggled to get through to the practice, and maybe put a slant of kind of duty of care and patient care on the conversation around the need for that more urgent communication with the practice, rather than it being kind of focused on it's taking me a lot of time to get through to you. Actually, this is a patient care issue, and see what the practice have to come up with. Ricky, I don't know if you've got anything else you could add to that one. Ricky, you're just a little bit quiet, sorry. I don't know if you need to put your microphone up or lean forward a bit, sorry.
Is that any better?
That's better, thank you.
Yeah, no, I think you got most of that. Then the only other thing that I could suggest is I work very closely with some of our community pharmacy PCN leads, and they have in some instances been collating some of those bypass numbers for surgery. So if you haven't contacted your PCN lead, it might be worth just checking in and seeing if there's something being sort of pulled together in the background, just as another option. And that's for more broader stuff, not just GP CPCS, but it might be something that you find helpful.
Thanks, Ricky. Does anybody else have any other questions for us? This is your opportunity now to ask any questions that you might have before we close the session today. Any more questions? We've had some good conversation this afternoon though. Thank you for those who have attended. Hopefully you found the information that we've provided helpful and useful for you, no matter what stage at GP CPCS you might be at. If you do need any more information about GP CPCS, then your first port of call is your LPC website. So Bolton LPC if you're in Bolton, or GM LPC if you're in any of the other 9 GM localities. Both of the LPCs have got a dedicated page for GP CPCS. There's lots of resources in there, there's lots of information, and those updates that are sent out bi-weekly can also be accessed through the LPC website. So if you're not sure where the practices in your area are up to with regards to going live with GP CPCS, then check your LPC website and get some more information from there. And if you've got any questions, I'm sure your LPC will also be very happy to help out and answer any other questions that you might have. So I'll just give it another minute or two in case anybody has any other questions that they would like to ask. And if not, then we will wrap up the session for today. Any final questions? No? Oh, okay, brilliant. Well, thank you very much for attending this afternoon, everybody. Hopefully you find it useful. And as I mentioned, if you need anything else, then contact your LPC or check the LPC website. And I hope you have a great afternoon. Thanks, everybody, for attending.
Thanks very much, ladies. It was really good.
Thank you, Louise. And thank you, Haroon. Have a great afternoon.